I'm Chris Granger, and I'm delighted to be joined by Drs. Neha Pagadipati and Adam Nelson to continue our discussion about this really important topic of how can we improve the care of patients who have type 2 diabetes and cardiovascular disease, and specifically in this segment about how can we advise cardiologists and cardiology practices on how to assemble the team and develop and implement care pathways to make sure that these treatments are in fact being implemented in practice. And I'm especially glad to have Neha here because Neha is part of our academic team around implementation science and really looking at this in an evidence-based way. How do we change practice at the point of care? And Neha, we've reviewed in our last video that almost nobody is getting all these treatments that we know would provide benefit. Only 10% are getting an SGLT2 or GLP-1 receptor agonist, even in a commercially insured population where cost is not an issue. And so obviously there are barriers in place that we need to overcome. And so what do you advise to our audience about how to identify and overcome these barriers?
That is an excellent question, and I think it helps to think about the different barriers kind of at the levels at which they take place. So there are, some provider level barriers, which are just, there's the general kind of treatment inertia. I've been practicing this way for a while, though I think, in some ways, I hope that that's overblown. I do think that providers want to do the right things for their patients, but there is this kind of overload of information that's coming to us continually, and it's almost impossible to keep up with all this information, and how do we assimilate this and kind of put it into day-to-day practice is difficult for folks. So there's somewhat of a comfort level and an education barrier there. I think there also are some concerns, especially with these agents that you've mentioned, that are traditionally thought of as diabetes agents, but which we have discussed in the last couple videos that they're really cardiovascular risk reduction medications. But there is some concern over, is this in my scope? Does this mean that this is going to mean that I have to take care of diabetes overall? What will this mean for my referral patterns? Will my colleagues in endocrinology and primary care be upset with me, and so forth? So I think that there are several of those kind of barriers that happen on the provider level. And then, of course, there are system-level barriers, and cost being one of, if not the major one. And it affects patients with all different types of insurance, and, of course, those who are under or just uninsured completely. In terms of figuring out how we as providers in day-to-day clinical practice address these barriers, I think one really key principle that we have discussed before is this idea of working in teams to create care pathways. I think the idea of leaving each individual provider to think about it on their own, address all their barriers on their own, and do the right thing for their patients is just working in a system that's just set up against us in some ways. And I think if we can kind of work within our own particular clinics to set up systems that help us do the right thing, then we're off to a good start. And
okay, so let me stop you there, and maybe Adam, you might comment on this. So let's say you decide as a group that that using SGLT2 inhibitors is your first line drugs, and maybe even picking one or two of them and then describing which patients should be on them. Let's say you get your cardiologist to agree that that's something that cardiologists need to do to reduce cardiovascular adverse outcomes. So you've decided that. You've sat down, you've decided that. What's the next step?
That's a great question, Chris. And look, I think this is the real challenge, as Neha's already mentioned, that these came out as glycemic drugs. We kind of were impressed with the benefits that we saw, but we haven't really got our hands dirty. And what I've found, and again, I kind of grew up with the SGLT2 class doing my IM boards, and we're talking to a prevention clinic director, so perhaps we're preaching to the choir a little bit, but once you start getting familiar with these drugs, it's not rocket science. And I remember one drug, I remember its dose. The others I look up, Chris. So I kind of get comfortable with one or two of them. As you mentioned, there's a lot of circuitous issues around funding these and getting them paid for. But in terms of familiarity with the prescription, it's pretty straightforward. There's got to be a spectrum. There's going to be a lot of people that want to just put the toe in the bathwater. There's going to be people who jump in knees deep and what have you. I think it's about just starting. We also forget that these agents, whilst we defer often to the PCP, they're still finding their feet as well. And so whilst we accept that, it's been more in their wheelhouse than it has been ours, we're still finding our way together. And so often, what I've found is the communication is just such an important piece of this. Whether it's picking up the phone, certainly the contextual discussion is more important than just a sort of letter that comes down the track. Having the discussion around, a patient, I've got this Mr. Smith with me, really keen to start an SGLT2. You avoid the issues around the transdisciplinary boundaries when you start to discuss it about an individual patient. I mean, that's kind of what I've found, Neha. Interested in your thoughts.
Absolutely. I completely agree. And I think having those conversations is really helpful, not only to improve the care of your patients, but also to improve that collaborative sense between providers. I will say that I've had a lot of those conversations. I've never had pushback, though sometimes you might expect it. I've never had an endocrinologist or a primary care physician say, "How dare you enter into my space?" On the contrary, I think the response has been absolutely great idea. Are you able to start it?
Yes.
Are you willing to start it? Yeah, I'll deal with the prior auth issues. That's fine. And we should talk about that as well. But I think that aspect of collaboration is actually a real benefit of these medications and is something that we can use to the patient's benefit as well.
One thing I've found too, Chris, has been, we've kind of been here before. We've seen the PCSK9 era, we've seen the DOAC era. I mean, have you sort of found that with your clinic too, Neha, that often the pieces are there, we just got to work out how to reposition them and sort of rework them?
Yeah, and I think you're getting at the cost issues, which we should absolutely get into. I think, we as cardiologists, we are not, the concept of really expensive medications that are hard to access is not foreign to us. I mean, we have been dealing with this for decades, if you will, and a lot of us have figured out how to do it for our patients, whether it's the PCSK9 inhibitors or the DOACs. And so it's very similar for SGLT2 inhibitors and GLP-1 receptor agonists. I think the main misconception that I have found is that these medications always require a prior authorization. And I will say in general, that's not true. Most commercial insurances at this point have at least one SGLT2 inhibitor and at least one GLP-1 receptor agonist on formulary. You don't always know which one it is ahead of time, but there is one. And so you can usually get away without doing a prior authorization. The same is generally true across states for Medicaid. So my Medicaid patients are able to get it, and I'm actually able to get it without problem for my patients who are completely uninsured, because the patient assistance programs through the companies is actually so excellent that if I have somebody to help them navigate that, they're actually able to get the medication. Where it can get tough is for Medicare patients, where you don't have the opportunity to give them a copay card. And depending on their level of coverage, they may not have, the copay may be too high, or they may enter into the donut hole. And that is where it's tough.
Right, Neha? And so it's true of NOACs, we have some, and it's true of PCSK9. There are some patients who simply, given our current system in the United States, there's some patients who simply are not going to be able to be treated with these drugs. That's the fact of our payment system. But I think the point is most patients
that's the minority.
Can, and most patients should. If you think about the team then, because we are a team now. We have, at Duke, we have, every other visit for somebody I see frequently will be by a advanced practice provider, a PA or a nurse practitioner. We have pharmacists who I regularly talk to about questions. We have Jennifer Green and others are diabetes experts in endocrinology for some of the challenging cases, because we also do have the challenge, the brittle type 2 diabetic who's on insulin, who has microvascular complications, who maybe had DKA, and for those patients, I really want an endocrinologist involved. So it's not a one-size-fits-all. But talk a little bit about how you would, kind of practical advice, because you've done this not long ago, set up a clinic that's been successful with this. How do you get that team engaged?
Yeah, absolutely. So there's several members besides very willing and eager cardiologists. Absolutely having diabetes care specialists, whether they're endocrinologists, primary care physicians, diabetes nurse educators, having those folks on the team is incredibly important, not only to help you when you're trying to come up with a general algorithm for how we as a team, how we as a clinic are going to take care of these patients, but also, as you said, to ask questions. So if I have patients where they're more complex, I think I need to get an endocrinologist or a diabetes care provider involved. If they already have one of those providers, great, I talk to that person. But sometimes they don't have that, and I need advice. So having somebody to go to who thinks the same way I do about these medications, that they're important for cardiovascular risk reduction, is extremely important. So having those, and it just makes me feel more comfortable. It just makes me feel less worried about kind of delving into this space. So that's one. I think having whatever support staff folks do have available, and that varies across clinics, whether that's APPs, whether that's nurse clinicians or other medical assistants or what have you, having folks be generally educated and aware of these types of medications and thinking about them. Again, like we said, just thinking about starting these medications is half the battle in some ways. So having the whole team understand what the benefit is and thinking about these medications is important. And for us in our clinic, having a pharmacist available, but a pharmacy tech who is able to navigate the cost issues, educate us and educate the patients about the cost issues, I would say is probably been one of the single most important things. And I understand that not all clinics have access to a pharmacist or a pharmacy tech, and so it can be difficult. But having somebody who is like your champion for in the clinic, whether that's a pharmacist, pharmacy tech, nurse clinician, somebody who is willing and able to navigate this complex system that we have to do it for the benefit of patients, I think is probably one of the most important things that we found in our clinic.
Yeah, that's a great summary. With respect to kind of measuring how we do, and I'll also say, we've mentioned this on one of our earlier videos, but while we're addressing these drugs, and let's say focus on SGLT2 inhibitors, there's also other things that are being underused in this population, like high-intensity statins, like ACE or ARB, making sure people are on an aspirin if they have established cardiovascular disease. So part of this approach should include kind of some of these broader issues as well. But back to the SGLT2 and or GLP-1 receptor agonists, Neha, one of the principles of implementation is you can't improve it unless you measure it.
Right.
So do you have advice on how people could have a sense about, how that right now we know almost nobody's doing very well with this, but even to see if you're making, let's say you're a cardiologist who's passionate about this, you bring your team together and you want to move the needle, how do you know if you're actually making inroads?
Yeah, it is a phenomenal question, and it's incredibly complex in the era of electronic health records and the many different types of electronic health records that we all have. But you're exactly right that it's hard to improve things that you don't measure. And so what we have started doing, and I think increasingly clinics across the country, whether they're part of large health systems or not, are figuring out ways to access their own electronic health record data for the benefit of their patient population and for quality improvement. So if you can do just a very simple search, whether that's through Slicer, Dicer, and Epic, or through something else in Cerner, or whatever electronic health record system that you have, if you can do something where you take a very discrete population of patients that you have, for example, those who have had an MI and who have type 2 diabetes, something simple, and then you just do a search to look at what proportion of them are on statin therapy, for example, ACE or ARB therapy, SGLT2 inhibitor, GLP-1, whatever else you're interested in. And you just get a sense of what that overall proportion is. It doesn't have to be fancy statistics, but that at least gives you a sense of where you are. And unfortunately, we're often surprised, and not in a good way, of what it is. And so that at least gives you a starting point. It gives you and your team motivation. I think it could give you support on kind of a higher policy level within your institution, that these are improvements that need to be made. And then being able to show where you go at 6 months, 12 months, 18 months, and so forth, can really give not only your team the motivation, but also the validation that what you're doing is important and working.
And that's good advice, I think, for anybody setting something like this up. And in fact, to give a plug to the NCDR, it's the NCDR, I think, has been our go-to data source in the United States for cardiologists on how to measure how we're doing. And I think using the tools available there is something really important. Last question for you, Neha. As you set up your clinic and advising others doing this, what's your advice on going to your kind of clinic administration, your group, and saying, I want a nurse educator who's got some specific training in this area, or some other, what are the elements do you think that you should be advocating for your practice to acquire to do this well?
That's an excellent question. And some health systems are incredibly agreeable to providing resources to clinics and are able to provide resources to clinics that the clinicians and the providers think that they need. And in other health systems, it's tougher. And so you really have to prioritize what you would like, because we would all like a lot of things for our patients, but it's not always possible. I think for our cardiometabolic prevention program that we're developing here at Duke, we have several key components. One is just getting all of the providers and the different subspecialties together in the same clinic, co-located, so that we can learn from each other. And that is something we had to advocate for, because there are resources when you bring other providers into the clinic of a different division. So I think advocating for that has been important, but is not necessarily plausible for every clinical setting. Making sure that you have some element of education and training, and so for the APPs or the nurse clinicians, being able to train them, send them to conferences and so forth, I think is something worth advocating for, because then they become champions themselves. I think having a pharmacy tech within the clinic is probably one of the single most important things you can spend your resources on for improving patient care, but to help us navigate kind of that system. Beyond that, if you are able to have a diabetes nurse educator, I think that's wonderful. We don't have those resources, so we refer to our endocrinology colleagues who we work closely with. I think it's also incredibly important to have a dietitian in your clinic. We don't yet have those resources. Working on it. And so all of those things are incredible, a smoking cessation counselor, those are all important things. But I think making sure that you have close collaborations with your colleagues who are going to help you do this, making sure that your immediate group is well educated and motivated, and sending them to conferences and things like that, and then trying to get a pharmacy tech. I would think that those would be some of the key things to build a successful program.
Great. Well, that's a terrific summary, and thanks so much for your advice based on the experience that you've had. And Neha and Adam, I'd like to thank you for another terrific discussion around this critically important topic. And I hope we've been able to provide our viewers, cardiologists, advanced practice providers in cardiology clinics, some information about the compelling case for improving care for this population, about these tools that right now are grossly underused, and that would substantially improve the health of our population if they were more consistently used. And then maybe most importantly, practical advice that these drugs can be used relatively easily and safely by cardiologists, because they are cardiology drugs.
That's right.
And I think this is really a call to action. We're saying cardiologists must do this if we're going to be providing high quality care to improve the health of our population. So thank you, and thanks to our viewers.